Welcome, and thank you for tuning in to On the Go with CAO, a podcast by the Centers for Advanced Orthopaedics. Join us as our orthopedic specialists share their tips and advice for keeping you on the go and in the know, including the latest on how we're treating and caring for injuries and diseases of the body's bones, muscles, joints, ligaments, and tendons. We're here with over 60 offices in Virginia, Maryland, and DC to keep you active and on the go.
Welcome to On the Go with CAO. I am Dr. Beatrice Grasu, and I am a hand and upper extremity specialist with Centers for Advanced Orthopaedics. I work at the Baltimore, Maryland orthopedic division called OrthoMaryland, and with me tonight I have Dr. Harrison Solomon, also a hand surgeon.
Great. Well, we're so happy to be here to talk about hand and upper extremity surgery, something near and dear to our heart.
And since you've mentioned surgery, which obviously we are somewhat passionate about, can you talk to me about just latest techniques or advancements in hand surgery?
Sure. Well, I think a big advancement for me in my practice, which has been popular for me and for the patients, has been actually wide awake hand surgery. Mm-hmm. And it may sound a little scary at first for some patients, but it's been a great experience for all, in which by anesthetizing the hand with local medicine that's mixed with some different medicines to control the bleeding and allow us to do the surgery safely. In the office, we can take care of a fair number of these smaller problems we see, such as trigger finger, which is a tendon caught in the hand, or a small cyst on the tip of the finger, which can be related to arthritis, or, as you mentioned earlier, Dequer veins tendonitis, which is another very painful tendon problem at the base of the thumb near the wrist. And so wide awake surgery has been a big plus. It's easier for patients. They don't need to go under anesthesia. They don't have to stop eating and drinking after midnight. They don't have to get pre-op studies. They don't have to go to a different facility, change their clothes, on and on and on. And it's actually nice to be able to talk to the patients mm-hmm. during surgery, and you can go over not just what's happening at the moment, but how are things going to be afterwards and what to expect. And there's a little bit more patient engagement and buy-in with that. So that's been a popular new advance, which I think is only growing.
Yeah, I like the patient engagement aspect to it. I like that when, as you mentioned, the trigger finger, the finger is locked down in this position and that they can see the improvement then and there. So I really like it. We are at our division, we're still doing it in the surgery center in a procedure room. But patients, as you said, can have breakfast, they can drive themselves. Hopefully we will be moving forward to doing it in the office as well, because I think that's a huge advantage.
Sure. The big thing is just doing it awake, I think, mm-hmm. and then moving it to in-office is just the next step. But it is really nice, and I think our results when we do it that way are even better mm-hmm. For some very reliable procedures. And I would just add, for anyone who seems squeamish, even the most nervous patients have had really great experiences. And there's some dramatic cases where it's really just not for everyone, and that's okay. But in general, people have really liked that.
So tell me more about how you're doing your in-office procedures, how patients are positioned and how you're interacting with them.
Sure. Well, when we do wide awake surgery, the first step is to anesthetize the hand. And for me, they're usually just sitting face to face. The hand comes out. I'll draw out the incision, and I'll use numbing medicine with the tiniest of tiny needles that they can barely feel to anesthetize the hand. And then we have to wait a few minutes for the anesthetic to really go into full effect. Then we'll switch rooms, and they will just lie down. They go onto their back, and we have a table on the side, and they put their hand out. So as a general rule, they're not looking at the surgery. They're more looking up at the ceiling, and we're talking about what we should play on Spotify or the weather or their kids or something to distract them from the process. But if they want to talk about it, they can. It's hard to really see it just because of the positioning. However, I remember a patient who is a cameraman on Meet the Press, and she filmed it with her cell phone. She couldn't resist, so somehow she got a good video of the surgery.
I like to in the surgery center. I'm putting up all these blue drapes so they really can't see, and I try to reassure even anxious patients, like, it's hard to see, but there are times in the surgery where I can bring the hand up and you can kind of look over and see the tiny cut, since we are working in a hole. And for those that don't have a queasy stomach, they like seeing the tendon move and see that their finger isn't locking when they're making a fist. So
absolutely,
it's an
I
interesting
think that's
experience.
great, and I think it's obviously, as you do too. I think offering that, there are so many different types of patients, and I'll usually say to someone during that type of surgery, do you want to see your tendon?
Right.
And you want to see your tendon move?
The inside of yourself.
And most people do. Yeah. I think more often than not. Yeah.
What are you doing for your carpal tunnel surgeries and releases? Are you doing that under local anesthetic in the office? Are you giving an option to the patients to do it maybe endoscopically, where a camera is placed underneath the ligament and cutting it kind of inside out?
Sure. I currently do most carpal tunnel endoscopically, and I usually still do it at the surgical center with a little sedation also, because when the instruments get right next to the nerve, that can be, as you know, very sensitive. However, I have had patients, as you also know, sometimes people in their 90s get bad carpal tunnel. It can be very painful. They really don't want to go to the surgery center, and you can do it under local in the office. So that's an option. Although I think for most people, the majority, I do endoscopically. How about in your practice?
I give them the option, and it's hard because at least like my physician-patient interaction relationship is to make the decision together, and I think patients sometimes want me to make the decision, but that's not how I operate. But I tell them the difference between the two is, are you going to sleep or not? If you're very nervous and you want some sedation, then let's do it endoscopically, because I think the recovery in the first week or two is a little bit faster than the open. And we're talking about, as you know, an incision that's the width of my finger versus an incision that's maybe 2 fingers long. So the open is a direct release right in the palm on top of the ligament to cut and open the space so that the nerve can kind of breathe again, wake up. And then the endoscopic, as Dr. Solomon mentioned, is going to sleep with some sedation, inserting a camera and an instrument underneath the ligament, cutting it from inside out. I think because you're not cutting the skin directly on the palm, that recovery the first week or two is a little bit faster. So I give patients the option, and I think either way the outcomes are no different long term. So whichever way they're more comfortable is fine with me.
Yeah, a lot of ways to skin the cat.
Exactly.
And dovetailing on that, one common misconception that I would love to address here. Sometimes people come in and their hand hurts, and they say, Dr. Grasu, I have carpal tunnel syndrome. And what do you say to them?
I ask them if their hand is falling asleep. Are they having any numbness and tingling? And they say, nope, I'm having pain somewhere else. I say, I'm so sorry, that's not carpal tunnel. So carpal tunnel is a very common diagnosis that we see, but it is a condition where the hand is falling asleep, numbness and tingling. Oftentimes it starts with waking up at night, kind of shaking out your hand. And sure, maybe you did sleep on it wrong, but if it's a continued issue night after night or morning after morning, then come in, get evaluated because most likely something more is going on. And it can progress to where now driving or talking on the phone, you got to shake out your hand or switch positions. Again, we try to maximize non-surgical treatment with braces, plus or minus a cortisone injection. But the surgery works well if it's driving you crazy enough or if you're developing weakness in the hand, which is the end stage.
Yeah, like so many things we do, many people will never reach that surgical problem, but it's nice to know that you can cure it if you have to. But a certain percentage of people with that pinched nerve in their hand, carpal tunnel syndrome, they can manage it with a brace and over time, and this could go on for years or even a lifetime in some cases. So those are the kinds of options you get at any of our orthopedic offices in terms of treating these really common conditions, and also understanding what you have. Sometimes a lot of people with carpal tunnel, someone told them they had carpal tunnel. It might have been someone non-medical. It might have been a doctor who said, "Oh, your hand hurts, you have carpal tunnel." And but that, as we just heard, is not the case.
Yeah. Sometimes it's a tendonitis, sometimes it's a rheumatoid arthritis. We really try to figure out what's going on, and generally the exam and just the history really, answers the question here.
So, Dr. Grasu, in regards to arthritis, which is one of those conditions that we take care of commonly, surgically, what are the different options that you may offer someone who has arthritis in a particular joint?
So whether it is a finger joint or a wrist, there are replacement options out there. For fingers, I typically use a little silicone replacement. They do make some metal components, but I have not had a lot of experience with those. And then another great option, though patients get nervous when you mention the word fusion, is actually knitting the bones together, eliminating the motion, thereby eliminating the pain. And of course, when we're going to knit the bones together, we put it in a functional position that the neighboring joints are still moving, so it's not as if nothing is moving. And even with something big like a wrist, where the wrist isn't moving, it's like being in a brace permanently, and your fingers are still moving. We put it in a position that you can still use your fingers and grip things tightly and have, fine, dexterous manipulation. So those are really the two things that I'm thinking about when I see severe arthritis going on to surgery. What about you?
Yeah, just said in different words, the surgical treatment for arthritis is either fusion or replacement. And replacement also, especially for us in hand, does not have to involve foreign parts. And one of the more common arthritis operations we do is arthritis at the base of the thumb, where for most people we'll use an extra tendon or stabilize the joint, but we have removed the arthritic bone. No different than people getting hip and knee replacements. That joint and those bones are removed, in those cases replaced by plastic and metal parts. But in the hand, oftentimes we can stabilize with your own body parts, with an extra tendon that you have or something along those lines. And then also just expanding on something that you said, one reason why you go to a hand surgeon, we understand what joints are really important to move and what joints where some sacrifice of the motion is okay, if at the benefit of pain relief. And it varies by the joint. You would be really not likely to want to fuse a shoulder because we need shoulder motion. Whereas a joint like a wrist, if you can preserve some of the motions of it, but your fingers work and your elbow works and your shoulders work, that absolute range of motion of that joint, relatively less important. So
you can still golf, you can still play tennis, you can still go to the bathroom. So important functions can still be had.
That pretty much covers it.
Yeah.
If I could do all those things, sign me up.
We hope you enjoyed this episode of On the Go with CAO and invite you to tune in next time. To learn more about our upcoming episodes or to check out our online library of previously broadcast episodes, please visit cfaortho.com/hub. That's /HUB. Or search for On the Go with CAO on your favorite podcast app. Want to help keep others healthy and on the go? Then please share this episode. At CAO, you'll find over 160 orthopedic specialists committed to providing patients with an exceptional standard of care. The information contained in the On the Go with CAO podcast is for informational purposes only. It is neither intended as rendering medical advice nor as a substitute for seeking professional medical assistance. No relationship between the Centers for Advanced Orthopaedics and its practitioners may be created through On the Go with CAO. Any individual with specific questions regarding his or her individual health or treatment options should contact the Centers for Advanced Orthopaedics and schedule an appointment with one of its practitioners.